We go on to our next speaker, Dr. Shailesh, who's a senior consultant at Shekhar Eye Hospital, JP Nagar, Bangalore, and he's going to talk to us on something even more important, glaucoma and myopia, an update. And we know how often they coexist, and let's know what he has to say.
Hello, everyone. Yeah, thank you, Chitra ma'am. It was a wonderful, and thank you for inviting me for this wonderful, wonderfully conceptualized myopia panorama with a lot of interesting topics. And I will be dealing with glaucoma and myopia and uptake. And we all know glaucoma itself is a big problem. And to add to that, a double whammy, myopia is there. And that causes a lot of problems in dealing with these kind of cases. I'll just touch upon the salient features of how a glaucoma is presented in myopic patients. Myopia and glaucoma, we all know, are the commonest eye ailments. They constitute a majority of them. And it is increasing in the East Asian population. That is the worrisome fact of it. Glaucoma and myopes have variable progression and as compared to the OAG alone. And they also come with a diagnostic and management dilemmas. Now, the morbidity of myopia is not only restricted to the optic nerve, it also has got myopic macular degeneration, retinal detachments, cataracts, and amblyopia, strabismus, heavy eye syndromes, and so many other things which other speakers will deal with. I will touch upon the most important part of this myopia, that is glaucoma. Globally, we know that myopia affects 22.9%, and in 2050, it is going to affect 50% of the population. And in extrapolating to Indian scenario, it is 7.5% in children, 5 to 15 years, and 8.5% in urban and 6.1% in rural areas. It's again increasing by 2050. So we have to be very careful about this situation. A lot of studies have associated with this myopia and glaucoma, and they have come up with different linkage. So commonest being the Blue Mountains eye study done in Australia, where glaucoma is present in only 1.5% of eyes with myopia, whereas in 4.2% eyes with low myopia and higher number of 4.4% in moderate to high myopia patients have glaucoma. In Beijing eye study, high myopia of more than 6 diopters have a high risk of developing optic disc glaucoma. Singapore Malay eye study, where Southeast Asian population has been touched, where there was high risk of 3 times higher risk of developing open angle glaucoma when the myopia is more than 4 diopters. This graph shows in myopia how the refractive shift happens as the age also increases. So this is what at around 15 years, they all tend to stabilize. Along with myopia, we know that it is open angle glaucoma. That is one which we see. Many times we see a young individual with pigment dispersion and they won't have any myopic symptoms. And once we carefully do refraction and all, we pick up the myopia. These are young males with moderate myopes, and they have spontaneous fluctuation of IOP and transient blurring of vision on and off, especially when they do exercise on gym or they run or jog or some other issues. And they have high IOP without any field loss. So we should be mindful of this situation with a young myope having some blurring of vision, having pigment dispersion syndrome. There are a lot of associations I would like to tell with myopia and intraocular pressure. If the pressures are less than 20, and if the myopia is moderate to high, there is 2.2 odds ratio of developing glaucoma. Whereas if the IOP is more than 20, and if the myopia is high, then there is 4.27 times the chance of developing glaucoma. Same thing with axial length and IOP. So if the IOP is less than 20, and if the axial length is 25.5, there is 2.85% chance of developing glaucoma. Whereas if the IOP is high, along with that, the axial length is also high, it is 16.2%, exponentially high. So axial length and IOP are very important factors. Now, myopia also comes with its own diagnostic dilemmas. In clinically, we have to just measure the IOP at the various points of time, not only in one time, morning, afternoon, evening, whenever it's permissible to have a very consistent IOP values so that we know there is any diurnal variations or not. Optic nerve head evaluation, they bring some challenges which I will explain you later. Investigational challenges are there in terms of OCT of optic nerve, visual field evaluation, and disc photos. Now, there is what makes myopia a very challenging one because of its anatomical predisposition. There is axial length elongation, thinner lamina cribrosa, there is decreased scleral rigidity. And when you see the optic nerve head, we have that nasal insertion, we have a larger disc, we have tilted disc, and we have shallow cupping. And along with that, we also have these kind of peripapillary changes like atrophy, scleral crescent. these are the different types of optic nerves that we see in glaucoma patients with the tilting of the optic nerve, and there is the scleral crescent and then peripapillary atrophy along with macular degeneration. You have a very classical tilted disc, but it is essentially a normal nerve. These are the range of optic nerve heads we see in glaucoma patients, and we get confused whether we are dealing with just a myopic optic nerve or a glaucomatous optic nerve. We have a tilted large cup, then there is a myopic tessellated background, then we have this increased peripapillary atrophy, and then the staphylomatous optic nerve associated. Again, some sets of optic nerve heads. Now, optic disc area also increases when the refractive error also increases. This is one graph which mentions. Now, what is the other part of measuring the glaucoma is in terms of retinal nerve fiber layer imaging. And the relationship between axial length, spherical equivalent at the diopters and retinal thickness has been established. I've just come to this last two lines. Average decrease in RNFL happens when there is -7 micrometers of decrease in RNFL per millimeter increase in axial length. And if the refractive error is increased by 1 diopter, there is 3 micron decrease in the RNFL thickness. So RNFL thickness is something like CCT. We also have some evaluation in terms of axial length as well as the dioptric power. So OCT in myopia is also fought with a lot of challenges, like there is RNFL thinning, loss in early signs of glaucoma. Challenges in myopic eyes being that there are thinner average RNFL measurements. It is not well represented in the reference database. So the database contains the normal refractive errors up to 0.5, but beyond that, it is not representing. So we may have some issues here. And they may have a atypical distribution of RNFL with temporal shift in the RNFL fibers. So here is a case of OCT image with enlarged blind spots here, but it essentially the OCT is normal except for a few gray areas here. The other part of evaluation is that visual fields. So we have localized field abnormalities. There are so many other field abnormalities that we see in myopia with glaucoma. High myopia can cause field changes due to ventral nerve as well as retinal anomalies also. We should be careful about that. Visual field defects that favor myopia only over glaucoma are that there are temporal field defects, usually respecting midline as it is a tilted disc. Then there are enlarged blind spots. But visual field defects that favor glaucoma are typically a nasal step, arcuate scotomas, and paracentral scotomas. So we have to decipher these two things clearly. This is a summary of few of those visual field defects, like this enlarged blind spot, then the arcuate scotoma, and the nerves looks very suspicious, but and here is the nasal step. And here is one case where a glaucoma is being followed up, a myopic moderate to high myop, where from 1999 to 2015, we see that there is inferior arcuate defects, and they consistently present at one point of time. It looks like it is increased, and then again it comes back to its baseline. And the fundus photograph is almost similar to this. Here is the same patient.
Okay, 1 minute left.
Yeah, disc photos of baseline and even after 17 years, almost similar. But what we have to see is that we have to have a serious follow-up of visual fields which will pick up the glaucoma. So progression of glaucoma is also very important because field defects continue to progress despite good IOP control. Moderate to high myopia is a significant risk factor for progression of field defects. This is one case of myopia where there is superior arcuate, and here the fundus looks quite normal, but it's a small disc with the superior arcuate defects. Here is one case with a myopic disc with inferior small notching and corresponding field defects. So we have to correlate optic disc with the field changes. Now coming to the surgical challenges, once we decide that the glaucoma is going out of control beyond the medical management, we have to look into the surgical options that we have to see. We have to be very careful about the hypotony that is usually develops after a conventional trabeculectomy. So to mitigate these risk factors, we require multiple flap sutures, and tube shunts, which we usually use in these cases, also may need to leave patient at a slightly higher IOP in drop, and we should have a low threshold to have a refill of viscoelastic so to maintain the chamber. So there are a few things, last few slides. The missing links in glaucoma, many times we never forget to ask for refractive surgeries. Post-cataract surgeries also, patients will have a normal vision in these two situations, but they have not come for follow-up because their vision almost got restored to 6.6 or 6.9, and they won't come for follow-up. Remember that myopic degeneration still persists and glaucoma still exists. Never forget to ask history of any treatment. To start treatment, we have to have a risk-based approach, like discuss the patient, involve them. Sometimes we have to start in young patient where we have a poor follow-up. We have to give medications and we have to discuss the patient about the pros and cons. Field effects are closer to fixation. We have to treat them. Associated conditions where there is migraine, sleep apnea, low BP, anemia, we might err on the side of treatment. Recent understanding about the myopia and glaucoma is that in the investigation part, macular OCT measurements of ganglion cell complex and macular retinal nerve fiber layer inner plexiform layer complex may provide better glaucoma detection than the standard RNFL measurements. In summary, strong link is there between myopia and glaucoma. Myopic eyes show structural and functional defects that is difficult to distinguish from those caused by glaucoma. Longitudinal follow-up is required in terms of regularly evaluating the IOP, its fluctuations, field defects, consistent field defects, OCT. Be careful about the red eye disease where the temporal and the inferior RNFL converge on the temporal side and cause this red eye disease. Fundus photos are very important in help in picking up the progression. A serial fundus photograph has to be taken. Keep a high index of suspicion, especially in young patients. Surgical options have to be explored, keeping in mind the scleral thinning and the associated hypotony. Now, this is to end with this is an interesting slide, which article, Glaucoma and Myopic Eyes by Arnold Knapp. It was done in 90 years back, like none of us were born. He said that although the diagnosis of glaucoma in these cases is difficult, repeated tonometric and perimetric examinations would indicate the line of treatment. We have not gone far ahead from this statement, which was done 90 years back. Only OCT and few other treatment modalities have been added. Thank you.
Thank you, Dr. Shailesh. That was a wonderful talk and it was interested me a lot being glaucoma.
Yeah.
Then what does it mean? Would you be a little more thoughtful about using mitomycin and myopes with glaucoma?
Absolutely, yes, ma'am. Any surgery, we have to be very careful in terms of maintaining the anterior chamber and using mitomycin. So they are and have a very tight flaps so that hypotony is avoided. Mitomycin is also fraught with hypotonous maculopathy, and we have to be careful, or we have a lower dose of concentration of mitomycin. See, many times we operate in young patients. Myopes with young patients develop glaucoma. So myopes and young patients have got very thick tenons and they have very aggressive reaction. So we have to balance between the hypotony as well as the mitomycin C concentration. But the best way is to have releasable sutures, have a tight flaps so that you don't have hypotony in the post-op.
Yeah. What about IOP measure in those post-LASIK patients? Would you hold on to Corvus or Dr. Ramanjit's concept of measuring the temporal sclera?
Yeah. Away from the center, there's one, our dynamic DCT is Pascal one. We also have the ORA's ocular response analyzers, or we also have, and I think you are the best person to tell this also because you do both glaucoma and refractive surgery. And many times we even do our own applanation tonometer, and there is some correction factor, just like CCT. We can just underestimates, but at least we have applanation commonly. We should keep in mind that it is underestimating our IOP. So accordingly, we have to adjust to the age, the optic disc finding, visual field changes.
Thank you, Dr. Shailesh.